Okay. Hi, I'm G. I'm a student at Advent Health University, and I'm going to be showing you some tests today to rule out a high ankle sprain or to rule it in. The first test we're going to do is the Kleiger test. I'm going to stabilize the distal 1/3 of the tib fib. I'm going to apply an external rotation of the talus and try to reproduce that syndesmosis pain, which would indicate a high ankle sprain, and that would be a positive, would be pain with this motion. I'm going to apply the cotton test, where I'm going to stabilize the distal 1/3 of the tib fib, and I'm going to apply a lateral force of the talus. I'm trying to reproduce the patient's pain. However, if there's increased laxity, you could feel a clunk. And then I could switch my hand position here and apply a medial glide as well. And again, pain would be increased motion, or a positive would be increased motion or pain or that clunk. Okay, so I'm gonna do the squeeze test. I'm gonna try to compress the tib fib here. And if this reproduces the patient's pain, it could either indicate a syndesmosis involvement. It could also be compartment syndrome, or it can be a contusion or a fracture. So now I'm gonna have the patient flip over. So I'm gonna do the heel thump test. Just thump it, hit your patient. And then if this is positive on the anterior shin, that could indicate a stress fracture. But if it does reproduce the pain in the syndesmosis, then that would indicate a high ankle sprain. Now I'm gonna do the fibular translation test. So I'm going to use the pad of my hand to translate the fibula, and I'm trying to reproduce his pain. So I can do an anterior glide of the fibula and a posterior glide. And if it reproduces his pain, then that would indicate a positive high ankle sprain. So the next couple of tests that I'm gonna do are for the lateral ankle sprain. I'm gonna do an anterior drawer test to see if there's ATFL involvement. I'm gonna stabilize the distal 1/3 of the tib fib, and I'm gonna grab the calcaneus and apply an anterior glide. I'm looking for excessive movement or like a gapping or a clunk. That would be positive. The next test I'm gonna do is the Taylor tilt test. And of course, with all these tests, I'm gonna do the uninvolved side first to see what kind of motion they have. So I'm gonna place my thumbs just inferior to the lateral malleolus on the talus, and I'm going to do an inversion of the talus and try to see if I get that gapping or excessive movement, which would be positive if I'm getting excessive movement, a clunk, or like a gapping at the talus. That would indicate either involvement with the CFL or the ATFL. So the next test I'm gonna do is to assess for the vascular system, specifically a DVT. If the patient's complaining of pain in the calf, what you could do is just squeeze the calf, and you're looking for a reproduction of that deep calf pain. You can also put the person into dorsiflexion, again, squeeze with the calf, and you're looking for a reproduction of the deep calf pain, which could indicate a DVT. So the next test we could do is the Berger's test. I'm gonna raise the leg up to about 45 degrees. We're gonna hold it here for 3 minutes. I'm observing the foot to see if there's any blanching or collapse of the veins. After, let's say it's been 3 minutes, I'm gonna drop the foot down into the dependent position, and I'm assessing the color return in the foot. So if it takes longer than 30 seconds for the color to return, then this could indicate some peripheral vascular disease. Okay, the next tests I'm gonna do are to assess the integrity of the Achilles tendon. The first test I would do would have the patient in prone, and I'm gonna squeeze their calf, and you should see plantar flexion of the foot. Unless there's a complete rupture of the Achilles tendon, you would squeeze and there would be no movement, and that would be a positive sign. Test is gonna be the Matlis test. So I'm gonna have the patient bend his knee up slowly. Okay. So I wanna go to 90 degrees, and what I'm looking for would be a drop of the foot, indicating that, the Achilles tendon is not connected, and so that talocrural joint would kind of sag down, and that would be a positive sign for Achilles tendon rupture. The last test I'm doing is the Royal London Hospital test. So I'm gonna have the patient point your toe down. Okay, I'm gonna palpate along the Achilles tendon. Do you feel pain?
Yes.
Yes. So now I'm gonna have you pull your toe down. Okay, perfect. And I'm gonna palpate in the same area. And what do you feel now?
It's better.
And if the pain is less with max dorsiflexion, then that is a positive sign and it indicates Achilles tendinopathy. So the next tests we're gonna do are to identify neurological involvement if the patient is having numbness or tingling in the foot. We could do Tinel's sign. If we tap on this, we can assess the anterior branch of the deep fibular nerve, and I'm trying to reproduce the nerve pains like numbness, tingling, or a zinging. We can also assess the posterior tibial nerve here, which is medial to the medial malleolus, and we'll tap on that. And again, I'm trying to reproduce the numbness or tingling, and that would be a positive finding. Okay, so the next test I'm gonna perform is the Morton's test or Morton's squeeze test. If this individual is having pain between the second to third or third to fourth metatarsals, you can come up here. We're gonna squeeze on the metatarsals, and I'm trying to reproduce that numbness and tingling or the burning. If the patient has reproduction of their symptoms, this could indicate a Morton's neuroma. So the next test I'm gonna do is Feist's line. I've already marked the apex of the medial malleolus and the plantar aspects of the base of the first metatarsal, and then here's the navicular. And so I'm gonna put his foot on the ground. Let me have you scoot forward, but don't put weight through. So without weight bearing, I'm just looking at the navicular, which it looks like it's in the Feist's line, which is normal. Now I'm gonna have you put weight through the foot. And again, I'm looking at the navicular. If the navicular drops all the way to the floor, then that would indicate, it would be a positive test finding, and it would indicate like a flat foot. So now I'm performing the functional hallux limitus. I've already found the subtalar joint neutral, and so I'm going to passively be moving this toe into extension. And as I move the toe into extension, I'm looking at the first ray, and so he would be negative because when I move the toe into extension, I don't see any plantar flexion at the first ray. However, if I did move it into extension, this first ray plantar flexed in order to get to extension, that would be a positive functional hallux limitus test. So the next test I'm gonna perform is the windlass test for plantar heel pain. I'm gonna have the patient in weight bearing, and their toe is gonna be hanging off the edge. So I'm gonna apply passive extension at the MTP joint. And if this reproduces the patient's heel pain at the plantar fascia, then that would indicate positive plantar fasciitis pain. That's it. Thanks for watching.